Hello, everyone. Good evening. We will be starting in 3 minutes, allowing more participants to join. Welcome to the Journal Club webinar. Okay, I think we'll wait 1 more minute and we will start shortly. Okay, excellent. Perfect. So, Bismillah ar-Rahman ar-Rahim. Dear respected ladies and gentlemen, Assalamu alaikum and good day for all of you from around the world. Thank you for joining us tonight in the second IVP webinar of IVPN Journal Club, season number 3. Our mission in IVPN Journal Club is to share the latest published evidence, learn from high caliber and world-class pharmacotherapy experts in analyzing primary literature, read beyond the trial's context, ultimately to optimize clinical practice. Tonight, we are a gathering of 180 delegates from different countries around the world who came to attend this live session with Dr. Marwa Hussein, who is a well-known double board certified clinical pharmacist in Egypt with a strong passion towards critical care medicine, research in the field, and teaching other healthcare professionals about the recent updates. Dr. Marwa Hussein, who will be introduced shortly by our moderator, Miriam, will discuss today whether haloperidol is an effective option for treating delirium in critically ill patients that will be explored through the METRIC trial tonight. Now, I will start by introducing our wonderful moderator tonight, Ms. Miriam Istanbuli, whom I can consider the greatest discovery of 2023. I started working with Miriam a few months ago, but she truly proved to be a genuine leader and excellent team player and a passionate future pharmacist. Miriam recently graduated with a bachelor's degree in pharmacy from Lebanese American University in Lebanon. She is the founder and leader of RxMeet program, a new international program for pharmacy students that showed huge success in its first version. This was launched in collaboration with IVPN students listserv. She has been always passionate about finding new and innovative strategies to improve patient care. This drive has led her to create a new and unique program that empowers pharmacy students to think outside the box, develop their own unique solutions for the healthcare industry, and collaborate with other students from different backgrounds and perspectives. Miriam aspires to pursue a career in healthcare consultancy, and without further ado, let's welcome Miriam to the stage to be our moderator for this webinar. Miriam, the stage is yours.
Thank you, Dr. Ahmed, for your introduction and for the opportunity to be part of the Journal Club and part of such dedicated team. So now it is with great honor that I would like to introduce Dr. Marwa Hussein, our esteemed speaker, who will be presenting today's Journal Club topic on haloperidol for the treatment of delirium in ICU patients, the AID ICU trial. So Dr. Marwa Hussein graduated from Faculty of Pharmacy, Cairo University in 2013, after which she became American Board Certified in Pharmacotherapy. In 2015, she started her career as a clinical pharmacist in a governmental hospital. In 2016, she started a new journey as a clinical pharmacist in a private hospital for 2 years. And in 2017, Dr. Marwa became American Board Certified in Critical Care Pharmacy. In 2018, Dr. Marwa joined Dar Al Fuad Hospital, and she is working there since then. Currently, Dr. Marwa is a senior clinical pharmacist there. She is also a member in the antimicrobial. Additionally, Dr. Marwa launched many educational programs in Dar Al Fuad Hospital for pharmacists, nurses, and physicians. Finally, Dr. Marwa is certified trainer of trainers in leadership and management from Washington University. So thank you again, Dr. Marwa, for being here today. And lastly, if anyone has any question, please feel free to write it in the chat box, and I'll be reading the questions to Dr. Marwa at the end of the session. And Dr. Marwa, I'll be leaving the floor to you now.
Hello, everyone. First of all, I would like to thank Dr. Ahmed Al-Awani and Mrs. Mariam. I'm glad to be there with you today. I will be talking about haloperidol for the treatment of delirium in ICU patients, the AID ICU trial. Our topics will be the definition and types of delirium, how can we screen for delirium, and after that, we will be discussing details about haloperidol and other trials done before about haloperidol. And after that, the AID ICU trials, discussion and conclusion, and finally the recommendations and the take-home messages. Okay, first of all, what's meant by delirium? Delirium is defined as an acute disturbance in attention and awareness, and it's the most common sign of acute brain dysfunction among critically ill patients. It affects almost 30 to 50% of the patients being treated in the ICU and increase morbidity and mortality almost 3 times. Delirium is divided into 3 types: hyperactive, hypoactive, and mixed delirium. Hyperactive delirium, in these patients, their symptoms are agitation, rapid mood changes, and hallucinations. For hypoactive delirium, patients have inactivity, reduced motor activity, and abnormal drowsiness. And some people have mixed type of delirium, hyperactive and hypoactive symptoms, switching between them. Okay, and so how can we screen for delirium? According to the pain and agitation and delirium guidelines, we have 2 screening tools, the CAM-ICU score and the ICD-SC score. The CAM-ICU score assesses for features, acute changes or fluctuation in mental status from baseline, inattention, altered level of consciousness, and disorganized thinking. Okay. To say that the patient have CAM ICU score positive, the patient should have acute change or fluctuation in mental status from baseline, plus inattention, plus either altered mental status or altered level of consciousness or disorganized thinking. So the patient who have CAM ICU positive screening tool, he should have 3 points, 1 plus 2, plus either 3 or 4. The second screening tool is the ICD-SC score. It consists of 8 items. To be positive, the patient should have 4 points of them, and screening is done between 8 and 24 hours. Symptoms are changes in level of consciousness, inattention, disorientation, hallucinations or psychosis, psychomotor agitation or retardation, inappropriate speech or mood, and sleep awakeness cycle disturbances and symptom fluctuations. So for all patients we will be speaking about, all patients will be screened for delirium twice daily using these 2 screening tools, ICD-SC score and the CAM ICU score. Okay. And now let's shift to haloperidol. We should know much more info about haloperidol. It's an antipsychotic compound. Currently, it's the most frequently used agent for delirium in ICU patients. Available in oral form, IM form, and IV formula, but kindly take care that the IV formula has the highest risk for QT prolongation, especially if the patient is receiving more than 2 milligrams. That's why IV formula has black box warning to be used. Doses of haloperidol may reach 100 milligrams per day, but for safety reasons, such as QT prolongation, it's not recommended to exceed 30 milligrams per day. If your patient have hypersensitivity to haloperidol, or your patient is Parkinson, or have severe CNS depression or dementia, it's recommended to avoid haloperidol. Side effects of haloperidol, the most significant one are extrapyramidal side effects, hematological abnormalities such as leukopenia, neutropenia, and thrombocytopenia, and for sure QT prolongation, especially if the patient is receiving IV formula. Okay, and then Dr. Ahmed, could you please have the poll question?
Yes, sure, Dr. Marwa. I will show it now.
In your current practice, do you use haloperidol frequently in ICU patients with delirium? Kindly would like to share your practice with us.
Dr. Marwa, I will wait 30 more seconds and I will stop the bot.
Okay, that's perfect. Thank you.
Okay, here we go.
Okay, so 58% of our audience are currently using haloperidol frequently in ICU patients for delirium. Okay. Let's discuss trials done about haloperidol and then rediscuss our poll question. There is 2 other trials discussed before about haloperidol. In 2013, HOPE ICU trial was done, and 2018 MIND USA trial was done. In 2013, HOPE ICU was done to evaluate the effect of IV haloperidol on the duration of delirium and coma in critically ill patients. It was a randomized controlled trial, double-blinded, placebo-controlled, published 2013 to compare between haloperidol versus placebo group on the duration of delirium and coma. 142 patients were randomized, resulting in the regular use of haloperidol didn't prevent patients from the development delirium. And other studies will be needed to tell us if haloperidol is a useful treatment once delirium has been developed or not. The second trial is done to compare between haloperidol and ziprasidone for the treatment of delirium in ICU critically ill patients, the MIND USA trial. It was a randomized, double-blinded, placebo-controlled trial conducted at 16 medical centers in the United States, published March 2018 to compare between the use of haloperidol or ziprasidone as compared with placebo in patients with acute respiratory failure or shock and having hypoactive or hyperactive delirium in the ICU. 566 patients underwent randomization. They were randomized for placebo and haloperidol and ziprasidone. 184 patients was randomized for placebo. 192 patients were assigned for haloperidol, and 190 patients were assigned to ziprasidone. Conclusion was, haloperidol or ziprasidone as compared with placebo didn't significantly alter the duration of delirium. And now let's go to our main trial, haloperidol used for treatment of delirium in ICU patients. The 8 ICU trial. And here's the author affiliation. Agents intervening against delirium in the ICU unit, the 8 ICU trial, was done to investigate why the treatment with haloperidol would lead to greater number of days alive and out of the hospital than placebo, and also other clinically important outcomes in the ICU patients with delirium were also evaluated. The study was multi-center, blinded parallel group, placebo-controlled clinical trial with centralized randomization. Patients were screened between June 218 and April 222, generalized at 18 ICU in Denmark and Finland and United Kingdom and Italy and Spain. And finally, it was published December 2022. The inclusion criteria includes patients 18 years or older, having positive results on screening tests using the CAM-ICU score or ICD-SC score. Exclusion criteria were patients whom received other antipsychotic either in the ICU or before admission, and patients having contraindication to haloperidol, and patients who couldn't be adequately assessed for delirium because of language barrier or deafness or blindness, and patients whom had been involuntary admission to the hospital, and patients with delirium tremens who have confusion due to alcohol withdrawal. Eligible patients were randomly assigned to a 1-to-1 ratio to receive haloperidol or placebo. Randomization was done at a central location, use of computer-generated assigned sequence. All the committee were unaware of the trial group assignments, and haloperidol and placebo were contained in identical and pooled with identical labeling and couldn't be differentiated from each other. 1,738 patients were assigned for eligibility criteria. 738 patients were excluded, and 1,000 patients underwent randomization. 510 patients were assigned for the haloperidol group. After that, 9 patients were excluded, resulting in 501 patients assigned for haloperidol. On the other hand, 490 patients were assigned for the placebo group, which was saline. 4 of them was excluded, resulting in 486 patients receiving the placebo. In the group receiving haloperidol, 491 patients were included in the analysis of the primary outcomes, and 501 were included in the analysis of secondary outcomes. While in the placebo group, 472 patients were included in the analysis of the primary outcomes, while 486 patients were included in the analysis of the secondary outcomes. The trial intervention in the haloperidol group maximum daily dose of 20 milligrams of haloperidol. On the other hand, patients on the assigned for the placebo group were receiving 0.5 milli of placebo isotonic saline 3 times daily, also allowing for additional as needed doses up to 4 milli of placebo. Regarding the safety profile, Number of patients with one or more serious adverse reactions were similar in the two groups. No patients had more than one serious adverse reaction. The number of patients receiving rescue medication and the number of days with use of rescue medication were similar in the two groups. The assigned trial regimen was discontinued in 12 patients in the haloperidol group and 7 patients in the placebo group due to QT prolongation. After that, another 15 patients in the haloperidol group and 24 patients in the placebo group had discontinued their trial for other reasons. Physical restraint was done in 9 patients in the haloperidol group and 10 patients in the placebo group. And now let's go for the primary outcomes. Primary outcomes were the number of days alive and out of the hospital within 90 days after randomization, and death and length of stay at 90 days. Secondary outcomes was the number of days alive without delirium or coma in the ICU at 90 days, number of days alive without mechanical ventilation at 90 days, number of patients with one or more serious adverse reaction to haloperidol in the ICU, total number of serious adverse reaction to haloperidol in the ICU, and number of patients receiving rescue medication, and number of days with rescue medication per patient. Regarding the statistical analysis, it was a binary logistic regression and a linear regression model performed in the intention to treat population using R software version 4.1.2. It was estimated that 1,000 people should be required for the trial to have 90% power. And here is the basic characteristics of the patients involved in the trial. Outcomes were divided into primary outcomes and secondary outcomes. Primary outcomes, the mean number of days alive and out of the hospital was 35.8 in the haloperidol group and 32.9 group in the placebo group. That was 182 out of 501 in the haloperidol group and 210 out of 485 in the placebo group. Length of hospital stay was 28.8 in the haloperidol group and 26.4 in the placebo group. Regarding the secondary outcomes, days alive without delirium or coma was 57.7 in the haloperidol group versus 52.6 in the placebo group. Days alive without mechanical ventilation was 57.9 in the haloperidol group versus 53.9 in the placebo group. Serious adverse reaction in the ICU was considered the same in the two groups, 11 out of 501 in the haloperidol group and 9 out of 486 in the placebo group. Also, use of rescue medication was the same in haloperidol and placebo group, 288 out of 501 in the haloperidol group versus 302 out of 486 in the placebo group. And finally, days with use of rescue medication per patient was 2.9 in the haloperidol group and also 2.9 in the placebo group. Number of patients alive and out of the hospital at 90 days didn't differ significantly between haloperidol group and the placebo group. And these findings are added to the MIND USA trial that was done before. Response of the A trial, it was blinded and placebo-controlled design. It was large sample size, high level of completeness of data, validated diagnostic tools used for assessment of delirium. Enrollment, a broad population of patients with hypoactive or hyperactive delirium has been screened by clinicians, and this method will increase the generalizability of the results. And finally, the trial design allow as needed administration of haloperidol or placebo and the use of rescue medications. Limitations of the trial: low number of patients from international cities may limit the generalizability of the findings, and some eligible patients being missed from the inclusion as they have inclusion criteria. Lower enrollment of patients with hypoactive delirium than hyperactive delirium. Our conclusion: patients in the ICU with delirium treated with haloperidol didn't lead to a significantly greater number of days alive and out of the hospital at 90 days compared to placebo. So the conclusion: for ICU patients with delirium, it's always recommended to use the non-pharmacological management as recommended by the pain, agitation, and delirium guidelines, while haloperidol show no benefit. According to the guidelines, it's all recommended to use the non-pharmacological measures such as early mobilization, orientation activity to orient the patient and his family about the case, good oral hydration. For patients using vision or hearing aids, should provide the patient with them. Optimize sleep, minimum of 6 to 8 hours continuous sleep, and to avoid any intervention during sleep time. Good analgesics, and to avoid medications that can precipitate agitation. Always remember, it's a case-by-case assessment in the ICU during the critically ill patients. We should assess every patient individually to assess the better intervention for him. And here's our references. Before we end, I would like to ask again about your practices after knowing about the use of haloperidol in the ICU patients having delirium. Will we use it again as a primary or the first line for delirium or not? Would you think to change your mind or to change your practice after knowing more about the AIDS ICU trial?
Okay, Dr. Marwa, here are the results.
Okay, 74 will continue to use the same regimen and 26 will not. Okay. As discussed in the guidelines and the trials, it's always recommended to start with the non-pharmacological management rather than having the first line as haloperidol due to its safety profile and non-significant difference between placebo and haloperidol for the management of ICU delay. Okay, that's great. Thank you. And if anyone have any questions, I'm willing to answer.
Thank you, Dr. Marwa. So we have a few questions. So the first question is from Rawan Baidoun. She is asking you, why is haloperidol routinely used if it's not effective and has safety concerns?
It's malpractice. Usually physicians tend to use some agents as malpractice or having some false knowledge it will be effectively. But actually, after starting haloperidol, a majority of patients have QT prolongation, especially when the patient receives it as IV. As usually in critically ill patients, we try to avoid the IM administration for the risk of hematoma, especially if the patient is receiving anticoagulation. So after administering haloperidol IV, it leads to QT prolongation. So it's just malpractice or lack of knowledge, but not based on any medical evidence.
Thank you, doctor. So for the second question, someone was asking the use of haloperidol in depression.
There is no data about haloperidol as an antidepressant. It's mainly an antipsychotic. All the data about haloperidol is recommended for delirium or as an antipsychotic, as long-acting antipsychotic. But for depression, it's not one of the lines to be used.
Thank you. Sarwa Latif was asking if the data analyzed was based on the groups the patient were initially randomized to, or the data was analyzed based on the treatment the patient received. So is it intent to treat analysis or per protocol analysis?
Yes, it's an intent to treat analysis.
Okay, thank you. Yusuf Kanzitet was asking, so he has a question about the placebo group. What kind of adverse reaction happened in those with placebo group? How do you see this adverse reaction because the placebo group were taking NS?
In the trial, no mentioned adverse reactions for the group receiving placebo. No serious adverse events, differences or major differences between the haloperidol group and the placebo group. For sure, QT prolongation will be less reported in the placebo group, but no more adverse reactions reported in the placebo group.
Thank you. We have another question from Rawan Tafish. So as first-line pharmacological agent, which agent is preferred, haloperidol or quetiapine?
It's individualized according to the patient. As we talked before, the first line will be non-pharmacological agents. And second line, usually it's prepared to use a quetiapine as less adverse effect for QT prolongation. But again, it's always case-to-case assessment. But regarding QT prolongation, which is a major side effect of the haloperidol, quetiapine as compared to haloperidol has least effect.
Thank you for your answer. Nirmal Malik was asking, what cases do you think should be dealt with haloperidol specifically?
Usually, practical wise, we use haloperidol if you have used the non-pharmacological measures and it failed. And in some patients, we couldn't give an oral antipsychotic. For example, quetiapine is not available as IV form or as IM form. So we can use haloperidol if we need an injection form after being on the non-pharmacological measures.
Kashaf Sheikh was asking, how can we convince physicians to not use haloperidol for delirium?
We can discuss with them the serious adverse effects of haloperidol. And retrospectively, we can collect data about the patient received haloperidol in our ICU, monitoring their ECG, and he commented how many patients developed QT prolongation after using haloperidol. Especially, majority of ICU patients are receiving many other medications also causing QT prolongation, interacting with haloperidol. So we can use the data of side effects, the major side effects, and retrospective collecting the data in our ICU to be more specific.
Thank you for your answer. Someone was asking if haloperidol is effective in hiccups.
I didn't see data before regarding haloperidol using in hiccups. Maybe there is data, but I didn't check. But for me, I haven't checked before. I didn't see any reference using haloperidol as a treatment line for hiccups.
So Dr. Rizwan Ahmed Khan was asking if haloperidol is used for sleep.
It's small practice. Actually, it occurs. But according to the guidelines, haloperidol is not a sedative. As an adverse effect, it makes patients sleepy, but it's not the major cause to use it. So it's a malpractice. Much more recommended to use sedatives if the patient needs sedation.
Nushin Mahmoud was asking if someone uses haloperidol with citalopram, what would happen? Because we know that QT prolongation is a problem.
If we should both of them together, frequent ECG monitoring is recommended. In the ICU, patients are under 24-hour monitor. So these patients to be checked daily for ECG changes or any QT prolongation, and recommended to avoid any other medications causing QT prolongation.
Thank you for your answer. Dr. Faisal Gulzar was asking is there any effectiveness either of risperidone or olanzapine as they have been used for treatment of delirium?
Risperidone was tried in another trial, showing non-significant differences between placebo, but no other trials. But according to the guidelines, all of them are not recommended, and the recommended is non-pharmacological treatment. They can be used, but as a second line, not a first line.
Thank you, doctor. And Rabil Jimal was asking, were there any extrapyramidal side effect among the study participants?
In the side effects, it was not mentioned, or no data collected about the extrapyramidal side effects. But according to the haloperidol data, its safety profile, one of the major side effects is extrapyramidal side effects, especially with patients having risk factors such as patients' old age or patients receiving other medications causing extrapyramidal side effects, or receiving a medication interacting and decreasing the metabolism of haloperidol.
Thank you, doctor. And last question. So Ahmed Riyad was asking, where is it better to specialize in clinical pharmacy, in cardiology or critical care?
It's according to your preference, both are good. If you would like to specialize in cardio and your major work is in cardio ICU or in a CCU, it will be better. If you are working in a general ICU and managing patients' general medical condition, it will be prepared to have critical care knowledge. It's individualized.
So thank you, doctor, for your answers. And if anyone, does anyone have any other question you wish to ask Dr. Marwa? We can just wait a few seconds if someone needs to ask something. So I think all the questions were asked and answered. So thank you everyone for your valuable questions and for attending the webinar today. And thank you, Dr. Marwa, for your enlightening and informative presentation. And we hope that this Journal Club webinar was valuable to you. And kindly note that your certificate of attendance will be emailed to you within a week as of today. And regarding the recording of this webinar, it will be also available on the IVPN library within 7 days, should you wish to watch it again. And stay tuned for our upcoming Journal Club webinar on June 20 that will tackle aspirin or low molecular weight heparin as VTE prophylaxis after a fracture. And if you're not a member yet of our IVPN Journal Club community, please join us with one click at ivpnnetwork.com. And I'll be sharing the link in the chat box should you wish to join us.
Thank you, Mrs. Miriam. And thank you, Dr. Ahmed Al-Awani. I'm glad to be there to you. And thank you for all the participants.
Thank you very much. Thank you, Miriam. Thank you, Dr. Marwa. Appreciate it was amazing webinar tonight. Thank you so much.
Thank you.
Thank you.